Good afternoon. See, I'm getting it. Right? I'm getting there. Good afternoon. So, you're welcome for Wednesday, but I wasn't driving through ice and snow in the afternoon, so you're welcome, right? I know that I said online that I would post a video, but I've actually reworked the lectures and reduced kind of the amount of stuff, simplified it, so I actually kind of combined the two topics I want to talk about and finish up the chapter into one today. Okay, so we got quite a bit to do today, but it's really not that intensive. Okay, so today we're going to talk about the cardiac cycle, and then we're going to talk about cardiac output. All right, we left off on Monday. We talked about the conduction system of the heart and ECGs. Okay. So we went through and talked about how an action potential, an electrical impulse, travels through the heart, right? And when that action potential travels from the right atrium down through the ventricles, what happens to the heart tissue itself? Alexa, what is he doing? Okay. All right. So hopefully he's not texting. Let's move on. All right, so anyways, so what happens when the action potential goes through? What happens to the cardiac tissue? It contracts, okay? And so now that contraction leads to mechanical events that happen in the heart. That's what we talk about in terms of cardiac cycle, okay? So there's two parts to the cardiac cycle. There's systole, which is the contraction, and then there's diastole, which is the relaxation, okay? And how many of you are familiar with blood pressure readings, right? What's normal blood pressure? 120 over 80. And what's that top number? Systolic means during ventricular contraction, and diastolic is during relaxation of the heart, okay? So we have that during the two phases, all right? So that's what helps drive blood pressure, and also drives pulse and volume changes throughout the heart, all right, and through the peripheral blood vessels. All right, questions on those two parts? No? All right, so let's go through. There's three different parts to this. All right, first, we're gonna start at the beginning here with atrial contraction and ventricular filling, okay? Let's understand that 80% of the blood that fills the heart happens passively, okay? So at the beginning of the cycle, the heart is relaxed. Before the SA node fires, right, it is relaxed. The valves are open, blood is just emptying into the right atrium, the left atrium, right, and then flowing into the right and left ventricles respectively. Okay? So just like the faucet's on and it's just flowing in. Okay? What's the next step? What's the first step of contraction? SA node fires, and what does that cause? It causes depolarization of what? Of the atria. Okay? So the atria contract. Okay? So what you have here is the first stage. All right, we have the chambers, the atria are going to contract. Now before this, the atria are relaxed and blood is just flowing into the ventricles. Now the atria contract. What's the point of the atria contracting? What's that going to do? Casey?
Push the rest of the blood into the ventricles.
It pushes the volume of blood into the ventricles. Okay? So the atria contract. Pushes the rest of the blood. What happens to the pressure inside the ventricles when the atria push additional blood into the ventricle? Pressure increases, right? So understand there's going to be volume and pressure changes that are going to occur in here. If volume goes up inside a confined space, pressure has to go up. If volume goes down, pressure has to go down. Okay? So right now your AV valves are open. Everything's going from here, and it says ventricular pressure, right? It's right now, there's going to be changes in pressure that are actually going to help drive the closure of vessels as well, okay? So, atria contract, ventricles fill. All right, most of the blood is inside the ventricle. And it's now, we're going to start to increase pressure. Now we have the atria relax, and now we get to that point where we get to the AV node fires, the bundle of His, down the bundle branches into the Purkinje fibers, and what's going to happen to the ventricles? They're going to contract, right? This is an isovolumetric contraction. Before the ventricles, the ventricles start to contract, and it snaps the AV valves close, which is coordinated with what? AV valves close, and you, what is that? It prevents backflow, yes. And so it's the first heart sound is when the AV valves close, right? Snaps closed. And they are harder snap because they're bigger in size, and they're harder in, it's also increased pressure that forces them closed. So the ventricles contract, an isovolumetric contraction. The volume inside the ventricles is not going to change, okay? It's not going to change, but the pressure, what's going to happen to the pressure? Is this your water bottle? It is not. Okay. Okay. I'm going to give you an example of an isovolumetric contraction. There's not changing the volume of the water bottle, but if I change the size of the water, the vessel it's in, what happens to the pressure? It increases. And if I increase more enough, what's going to happen to the cap of the water bottle? That's what happens to the semilunar valve. You increase the pressure within the vessel without changing the volume, right? The volume within the ventricle then overcomes the volume behind the aortic semilunar valve and the pulmonary valve, right? And it ejects blood out of the ventricles. Whew. Questions? All right? So right now your atrial pressure, all right, and you kind of see how things work. And now the third part is your ejection that occurs. So we have atrial contraction, ventricular filling, an isovolumetric contraction within the ventricles is step 2, right? The AV valves close to prevent backflow, and then as pressure within the ventricles builds, it overcomes what's inside the vessels behind those pulmonary and aortic valves in order to eject blood. Okay? Now what happens? What's the second heart sound? Dub. Yeah. What's responsible for the dub? Let's put it that way. The semilunar valves are going to close. So how do they close? What happens now? Is all of that blood ejected out of the ventricle? And when does it stop? That's the next part. Okay? So now we come to the isovolumetric relaxation. Okay? The atria are relaxed during this time, so they're filling with blood from the vessels. There's a little bit of blood that is left inside the ventricles, right? So not all of it gets out, but there's, you can make a percentage of 80 to 90%, and you pick up a value out of that, but no one really knows because we can't stick a volumetric barometer inside your heart. Okay, but that's what we call an end systolic volume. All right, so right there, ESV, end systolic volume. That's the amount of blood that's left in the heart after ventricular contraction. Okay? So now pressure has increased, after contraction within the ventricles. The pressure inside the ventricles now is lower. What happened to the volume of blood inside the ventricles? Is it higher or lower than it started? Than the step right before this? Lower. It's lower. Okay, what happens to pressure inside the ventricles if the volume's lower? The pressure's less, all right? So now the pressure is higher out here, out in the aorta and the pulmonary trunk, and that snaps the semilunar valves closed. As they start to backflow, it parachutes open, and that's your second heart sound. Okay? So now the ventricles relax, okay? And that pressure allows the semilunar valves to close. So now we come back to everything. This is really the beginning where everything's relaxed. The atria are relaxed and open, all right? The ventricles relax. Now the pressure within the atria builds and forces the atrioventricular valves open, and blood then passively pools from the atria into the ventricles and also from the blood vessels into the ventricles. Okay? And now what would be the next step? We'd go back to atrial contraction for the next heartbeat. Okay? So it's a cardiac cycle of what's happened. It's a sequence. Important. The sequence of electrical stimulus relates to the sequence of mechanical events in order to have the most efficient pump process occurring. Okay? So you have SA node to AV nodes, the bundle of His down the Purkinje fibers. You have atria that are being filled with blood into the ventricles. Atria contract first, the ventricles contract second, pushing blood out. That sequence is absolutely important, absolutely necessary to have the most efficient process of pumping blood out of the heart. Okay? Questions on that? This is kind of, we put everything together in one slide. Okay? And I took this from another book because like I said, it puts everything together on one slide. Up top, well, I'll make this a little smaller. Okay? Up top, you see there's your PQRST, right? That's your electrocardiogram. There's your heart sounds. And then in sequence of what's happening within each of them, right? So pressure goes up, right? You have this important part right there. It's called the dicrotic notch, right? It's an area that discerns pressure, what's happening within the aorta, right? There's a little drop in pressure right there as the semilunar valves close, okay? All right, so that's your second heart sound. All right, and you have the atrial systole and how pressure was happening in there. And then you can see at the bottom right here, your ventricular volume, right? Before it's contracted, it increases in volume up to a certain point, and now you have contraction occurs, right? And now volume is being ejected. At this time, it's being ejected until the semilunar valves close, and then now it starts to increase in volume again up until the next contraction. Okay? And you can see the state of the valves. And at the bottom here, you can see what's actually happening in terms of blood during the different parts. Right? So we have ventricular filling, atrial contraction, and then we can break it into two different phases. The isovolumetric phase, the ventricular ejection phase, right? And then your isovolumetric relaxation back to ventricular filling. So it's a three-step sequence, okay, that just happens over and over and over again every second. Questions? So what happens when this doesn't work? What happens when the conduction system doesn't work right? What happens when the sequence is screwed up? You have a regular heartbeat. What happens to what's going out of the blood, of the heart? What's the job of the heart? To get blood to the body. If this doesn't happen in sequence, what happens to its efficiency in terms of doing its job? Come on, New England Patriots fans, do your job. Will it do its job? No, it's not. Okay, it's not meeting its expectations. All right, and that can cause a bunch of different problems. What that expectation is what we call, and this is the second thing we want to talk about, cardiac output. Okay? Cardiac output is defined as the volume of blood pumped out of the heart every heartbeat. Okay? So how much blood is being ejected out of the ventricles when they contract? It is maximized when the sequence of contraction is synchronous, right? So if you have the right cardiac cycle, atrial contraction, ventricular filling, ventricular contraction, ejection, right? That is maximized, right? That's the most efficient process. So your cardiac output is at its highest. Well, for whatever your heart rate is. Cardiac output depends upon your heart rate, beats per minute, times your stroke volume. Your stroke volume is how much blood is pumped out of the heart every beat. Okay? So, heart rate times stroke volume. Okay? Normal, it's about 5.25 liters per minute. So you're just sitting there. Okay? So if normal is 5.25 liters per minute, how much blood is normally pumped out of your heart every minute, every beat? What's normal at rest? So if we did it like this, right? CO equals HR times stroke volume, and your CO is 5.25 liters, right? Your heart rate is, what would we say, 65 beats per minute. Okay, what would this be? We have to divide 5,250 divided by 65. Go ahead, if someone with a calculator on their phone can do it. It's roughly what? What would we say? 75 beats per minute, about 70 mils per beat. Okay, this should be multiplied. So, cardiac output is directly proportional to heart rate and stroke volume. If one of those goes up, cardiac output goes up. Okay? So what happens to cardiac output when you exercise? It goes up. Why?
Because your heart rate.
Because your heart rate goes up, right? What happens to cardiac output when you are scared? It goes up. Why?
Increased heart rate.
Increased heart rate. Let me ask you, if you have a really strenuous activity or you're really scared and then you stop for a second, how does your heart feel in your chest? Pounding. That force of contraction. Okay? What do you think happens to stroke volume when that occurs? It also goes up. Okay? So the reaction, when those are two sympathetic nervous system inputs, okay? So sympathetic nervous system will work to increase heart rate and will also work to increase cardiac output, okay? Now, cardiac output, maximal, is about 4 to 5 times resting in non-athletic people, okay? So you end up a point where you kind of top out, okay? But in trained athletes, it may reach 35 liters per minute. 35 liters per minute. Let's figure out what that is, stroke volume. So 35,000, right? What would say a trained athlete heart rate probably, let's say just 100 beats per minute, just to make it easy. So what would their stroke volume be? 350, right? 350. That's about 5 to 7 times more than normal at rest. Okay? Your cardiac reserve, right, is your resting versus maximal. So if you went out maximal training, maximal exercise, your heart's pumping as hard as it can and as fast as it can, what could that pump do if it was at its maximum, right? Versus what you're doing just normally, that's your cardiac reserve, right? That's what you have potentially to do to get to. All right? So, let's talk. So if I have to regulate cardiac output, now at rest you have a normal kind of homeostatic state. Your cells of your tissues of your body need oxygen, they need nutrients. And it's the job of your heart to deliver those nutrients, okay? by transporting through the blood. So cardiac output is basically a measurement of how well your heart's doing its job, right? So if we measured this, we could regulate this by heart rate or stroke volume. Let's talk about stroke volume first, okay? So stroke volume is equal to end diastolic volume minus end systolic volume. What do I mean by end diastolic volume?
The amount of blood left after a diastole.
The amount of blood left after diastole. And what's diastole? Relaxation. What's happening when the ventricles are relaxed? It's filling with blood. So it's basically end diastolic volume is how much blood gets dumped into the heart before contraction. Okay? And end systolic volume is how much blood is left in the ventricles after contraction. Right? So how much comes in versus how much goes out. That's the difference, right? That's your stroke volume. Okay? What affects that? How about, what's one of the biggest things that affects how well your heart works? You think about all these heart disease commercials you have on there, what are they for? What do they work to help you with? What are the medications working? What about where the blood is going? Where is blood going from the left ventricle? It's going to the body. And how much blood gets pushed out of the left ventricle depends upon the pressure of the aorta or the receiving vessel. Okay? If I was to dump this out into someone else's water, how much I can put in is a function of how much capacity the receiving vessel has, right? So if I can't dump any more in, then that's it. I've reached capacity. Pressure goes up, and then those valves close, and that determines your end systolic volume. Okay, so blood pressure, if it's high, right, 180 over 100. Okay, that top number, if it gets too high, that means your heart has to work a little harder to get the same amount of blood out of the heart, right? To keep stroke volume the same. All right? Because it has to go against that other pressure that it's already there. So that's why blood pressure leads to heart disease. All right? So there are three main factors that affect stroke volume. Okay? We call preload, how much blood is coming in to the heart at relaxation. Okay? The contractility of the heart, how well it can squeeze, right? How well it can contract. And then afterload, right? And we'll talk about that in a couple minutes. All right? So about preload. This is defined as the degree of stretch of cardiac muscles before they contract. Starling's law. Okay? How well they contract, how elastic they are before contraction. Right? And this is a function of how much blood is coming back to the heart during relaxation. Okay? If I had a water balloon here, right, and it's empty, and I have a little bit of water, so it's not really distended yet. Right? And I fill it with water. What's going to happen to the water balloon? And I keep adding water to it. It's going to start to expand, right? That is the same process. All right? How much blood comes into the heart during relaxation affects how well the pump is going to push it out. Okay? If I start with a low amount of volume, I can only push out a certain percentage of that volume, right? I only have so much starting material, I can't eject more than what I started with. All right? And the heart is not a 100% efficient machine. There will always be a little bit of systolic volume, end systolic volume, that is of blood that's caught in the ventricles. Okay, so not all 100% of the blood that comes into the heart gets pumped out during every ventricular contraction. All right, there is a length tension relationship, just like any other muscle. How long the cardiac muscle is stretched, right? The longer it is, the harder it can contract. Harder contraction, stretch it by venous return, the preload, how much, I want to say water, how much blood is coming into the heart allows it to contract harder and send more out. Okay? The most important factor is what I've just mentioned, venous return. How much is coming back in? Okay? So we have our heart here. Okay? Venous return, our vena cava, okay, comes into the right atrium, right? How much blood is coming back in here so that it can get pumped in? Because then that's going to go out to, that's going to limit how much can go to the lungs and come back to the left atrium. All right? Most of your blood is found where? In the systemic circuit. Okay? So how much is coming back from the systemic circuit leads to changes in stroke volume. So we said what increases cardiac output? Give me an example of something that increases cardiac output. We've already said it here today. Exercise. Okay? Exercise increases cardiac output by increasing heart rate. And what else? It also increases stroke volume. Okay? Because when you start moving muscles to exercise, you start to push blood that's in your veins back to the right atrium. You increase venous return, you increase preload, you increase stroke volume as well. Okay? So exercise is even moderate exercise increases cardiac output. Okay? Contractility. Okay? Contractility is a function of the muscle itself. Okay? How well it can contract. It is independent of how much volume of blood is in there. All right? It depends on other outside things. It's increased by sympathetic nervous system innervation, right? It's increased by calcium. All right? There are two different parts that can help increase contractility by what's called inotropic agents. Okay? Positive and negative. All right? And they have to do with ions. Okay? Or other things that help influence how well the heart contracts. Thyroid hormone, glucagon, epinephrine. All right? High extracellular calcium, they all input and they positively increase the contractility of muscle, all right, of the heart muscle. And likewise, if we have positive agents, we have negative agents that work against them, right? Acidosis, which is having an increased blood pH. Extracellular potassium. What did I tell you about potassium earlier and how it works? What did I tell you about?
It could kill you because there's potassium out inside, so it can't go in.
Right, so potassium is used as a lethal injection because if it's too high, it can cause death. All right, extracellular calcium decreases, all right, heart rate, heart contractility, and can cause cardiac arrest. Right, and there are also calcium channel blocker drugs that can do this. All right, so preload, contractility. Now afterload. Okay, afterload refers to the pressure within the vessels that the heart is going to pump blood into. Okay, where the blood is going. Okay? That is the pressure that the ventricles have to work to overcome to push out, right, the amount of blood that's within the ventricles. All right, and I just said hypertension, high blood pressure. It increases afterload. Increases the pressure within the aorta and the pulmonary trunk. Now the heart has to work harder. All right, it actually leads to a increased end systolic volume, a decreased stroke volume, probably an increased heart rate in order to maintain the right cardiac output. Okay? Questions on stroke volume? We haven't even talked about heart rate yet. Well, a little bit we have. Just like there's positive inputs and positive and negative inputs for stroke volume, there's also positive and negative inputs for heart rate. Right? With positive chronotropic effects and negative. Give me an example of a positive chronotropic factor. Something that's going to increase heart rate. Anyone? Exercise. What else? Caffeine. What else? Nicotine. We had epinephrine. Right? Basically sympathetic nervous system. All of those are true. Okay? What about negative? So if we have the sympathetic nervous system increases heart rate, which one decreases heart rate? Parasympathetic. Right? And there's a bunch of other ones that are present. Okay? So here's your nicotine, cocaine. This is adrenal medulla is going to release epinephrine and norepinephrine. And they're all, right, thyroid hormone, caffeine. They're all going to work, right, by increasing the amount of cyclic AMP inside the nodal cells, which then lead to faster firing of the heart. Okay? Whether it's directly increase in norepinephrine or indirectly, doesn't matter. The endpoint's the same. We're going to have a higher heart rate. Okay? So, we have sympathetic nervous system. Norepinephrine causes the pacemaker to fire more rapidly, and it increases contractility. So, has a dual purpose, and epinephrine really has a large effect on heart rate. All right, and it works through beta-adrenergic receptors to increase heart rate. All right. It increases contractility as well, right? Faster relaxation. Okay? When it relaxes, it's only going to be relaxed for a very short period of time. Think about heart rate, right? What's the problem? The heart rate goes so fast, what aren't you not allowing it to do? You're not going to let it, it's going to have a shorter period of time to fill. Okay? But that's okay because it's increasing contractility. We're just going to push as much out as we can as fast as we can. Okay? So it kind of offsets that. Okay? The parasympathetic nervous system works opposite, antagonistically to the sympathetic effects. Right? And at rest, all right, at rest, you have what the heart exhibits what's called a vagal tone. Vagus nerve innervates the heart, sends messages from the cardiac center to kind of keep it at a nice low. All right, so parasympathetic has your dominant influence at rest. All right, to keep it at a nice 65 to 75 beats per minute. All right. There is something called the Bainbridge effect, or reflex, or atrial reflex. Okay? If you have an increase in venous return, where does the blood come from the venous return? Where does it come from? Where does it empty into the heart? So coming from the veins through what? So superior inferior vena cava and empties into the right atrium. Okay? If you have a sudden increase in atrial, like how much is coming back to you, to the heart, that atria is going to stretch. That's what we call this is what we call the atrial reflex. All right? So the atria stretches, and then that stimulates the SA node to increase heart rate. Okay? So when would you have a point where venous return goes down? Like blood that's in the system is just not coming back to the heart.
Like if you're like blood loss.
Blood loss, right? You have a hemorrhage. You have a large blood loss. How much getting back to the heart is going to drop? What's going to happen to heart rate? It's going to go down. So now in the clinic, you go into the ER, what do? What's the first thing they do? And they probably already do it they do it in the ambulance on the way over to the ER. They take your vitals. What are they going to do? Your heart rate's low and he's bleeding all over the place. What do we need to do?
Touch it up, or at least pressure on the...
Pressure. We have to stop the bleeding, but now you've lost X amount of blood. It's on the floor. What do we have to do? We can't pick it up and put it back in. What can we put in, though? We can wash it off first? Oh, yeah. We'll wash it off, spin it down. Anyone heard of IV fluids? Okay? IV fluids, what we're going to do is we're going to increase your blood volume. It's not blood cells, but we're just going to increase your blood volume to keep your heart rate normal. All right? Because your heart rate is going to you're going to notice you're going to have sympathetic nervous system's you're hurt, right? All right? They're going to recognize that and it's going to work to kind of go really hot, go really fast to keep cardiac output at a normal amount. Right? So you increase blood volume and help to prevent shock, right? And keep a heart rate at a normal pace. Okay? So this is kind of what we've talked about. Exercise, increasing venous return, any increase in contractility or sympathetic nervous system activity, right, will help to increase cardiac output. Those things are dependent upon each other, all right? Most of the things we've talked about not only affect heart rate, they also affect stroke volume, okay? So they actually affect both things at the same time, both factors at the same time, okay? And so you can see end diastolic volume goes up, preload's higher, increased stroke volume, increased heart rate. Both of them lead to increased cardiac output. Okay, this is in your book, in your text, shows you kind of the chronotropic agents, positive and negative, right? They increase and they change heart rate. Venous return, inotropic agents, afterload, they help work on stroke volume. These things are not necessarily mutually exclusive, right? Some of this stuff will work over here, okay? Or sympathetic and parasympathetic nervous systems can be classified both in chronotropic and inotropic categories. Okay? Other things. We have chemical regulation of heart rate. So not only the parasympathetic and the sympathetic nervous system, but hormones. Okay? Especially from the adrenal medulla, which is under sympathetic and parasympathetic innervation. Right? They release epinephrine and norepinephrine. Will work to increase heart rate. Thyroxine is what? Is also known as? You all passed your endocrine exam last semester, so hopefully you know what thyroxine is. Where does it come from? I'm going to start calling on people. Thank you. You are awake and alive, and you know something. Good. Thyroxine comes from the thyroid, which helps regulate your metabolism. So you have a hyperthyroid, you produce high thyroxine. What were you expecting? A high heart rate? Yes, that's one of the classic signs. Okay? All right, and then you have other intra and extracellular ions, right? Calcium and potassium, right? Those have to be maintained. If they're not maintained, you end up with problems. Right? Here's a couple examples. right? Hypocalcemia depresses the heart. Okay? Just the other day, my daughter's 13. She loves Gilmore Girls, right? And she's a big fan of Logan Huntzberger, who the actor has a new show called The Resident, right? And just the other day, so she's watching it and I'm watching it too. And just the other day, he had a point where there was something wrong in the show. Okay? Patient comes in and he goes into surgery and his father says, oh, he has low calcium. Right? So he's in surgery, losing a lot of blood. He has low calcium, and then all of a sudden, his heart starts going crazy, and he had a seizure. I'm like, no, his heart would stop. Right? It depresses the heart. It doesn't make it go faster. It depresses it. Okay? So that me being the professor, I'm like, that's wrong. Hey, my daughter Avery, she goes, Dad, just stop. I don't care. Just stop. All right. Hypercalcemia, increased heart rate, increased contractility. Hyperkalemia, right? This is high potassium. All right. I told you it alters electrical activity, right? And also can lead heart block and eventually cardiac arrest. And if you have not enough potassium, hypokalemia, you end up with a feeble heart rate and arrhythmias. Arrhythmias are irregular heartbeats, which are responsible from the conduction system. You don't have enough of that, the conduction system's broken, and the heart doesn't beat normal. Okay. Other factors include age, gender, exercise, we've touched on, and body temperature. Okay? Body temperature. Normal body temperature is about 98.6, but we all have our own set points. Okay? Whether or not your thyroid is overactive or underactive will alter that, and that will also affect your heart rate. Okay? And then some homeostatic imbalances or vocabulary. Tachycardia versus bradycardia. Tachycardia is abnormally fast heart rate, greater than 100 beats per minute. Now that's not necessarily, if you're exercising, that's normal. If you're at rest and it's that, you got a problem. Okay? And it could lead to fibrillation. What's fibrillation? No, that's defibrillation. He went, yeah, right? Yes, but it's a problem with the electrical conductivity of the heart, right? There's out of sync, then we have to reset it. Bradycardia is a heart rate slower than 60 beats per minute on average, on normal, right? And it could result to problems delivering blood to the circulation, all right? And 60 beats per minute, maybe just if you have someone who's an endurance trainer, triathlete, marathon runner, it's not uncommon that they be at or below 60 beats per minute. Okay? Other problems, congestive heart failure. Okay? This is a progressive condition. Cardiac output is so low that your circulation is inadequate to meet the needs of your tissues. So what happens to your tissues? They start to die, all right? And it's usually a result of the muscle wall being weak for whatever reason, okay? We could have clogged arteries, persistent high blood pressure, okay, for a long period of time, multiple heart attacks, your heart's not working as well, right? And dilated cardiomyopathy, whatever it might be. So congestive heart failure, your pump is tired. The heart's tired, it's not working, it's not pushing enough output to meet the demands of the system. Okay? And then finally we have what happens when failure of one side versus the other. Okay? Pulmonary congestion or pulmonary edema. How much comes in to the right side of the heart, right, also depends upon how much is going out from the left side of the heart. We've talked about this as being a two-sided pump, but the two sides depend on one another. Okay? So how much blood comes into the right side determines how much goes out to the lungs, and then how that volume comes into the left side. So if the left side fails, the right side's going to back up. The lungs get full with fluid. And you have swelling. That's what edema is. Okay? And then peripheral congestion or systemic edema, the right side fails. So the left side's still working and pushing blood out, and then it's filling up on that side. Right? Ultimately, one side fails, the other side is going to have to work harder for a little bit, and then it weakens over time, fatigues, and then you end up with failure. You treat by removing fluid, reducing afterload, and increasing contractility. All right? Questions on the cardiac cycle and cardiac output? Nope. That finishes what the material for your exam is for next week.